Okay.
You are live now, sir.
So good evening everyone. Myself Dr. Prafulla, Secretary DOS. I'm welcoming you all and thank you for the huge response that you people are showing us to in this webinar series. And today we are continuing with the webinar series that we have started with the help of Cipla Pharmaceuticals. And this is our webinar series which is going to be number 4. And this is on a very important topic about which you must have heard in all the conferences, but rarely you get enough time to hear about that. So that's why we planned this 1 hour long webinar. And here, Dr. Madhu is going to cover one important topic, that is meibomian gland dysfunction. And I hope you all will like that lecture. And now I request our moderator for today, Dr. Anu Malik, to introduce our speaker, and then we'll move ahead with the talk. And just to update you, at present we have 180 live attendees, and overall registration is almost 700. So we have 179 live attendees. So thank you again for all the audiences who have joined us. Dr. Anu, can you introduce our speaker for today?
Good evening, everyone. Welcome to DOS Super Tuesdays webinar, an initiative by Delhi Ophthalmological Society, with very special thanks to our President, Dr. Rohit Saxena, sir, and Secretary, Dr. Praful Kumar Maharana. So this is our 4th episode of Dry Eye Clinics, and I extend my warm welcome to our distinguished speaker for today, Dr. Madhu Udaraji. He is the Chairman and Managing Director at Dr. Ramana Raju's Vision Tree, Vishakhapatnam, and he is currently the Chairman Scientific Committee of Andhra Pradesh Ophthalmic Society, advisor and Indian partner at Harvard Global Alliance for Medical Innovation. He has performed over 2,400 corneal transplants, over 2,800 refractive procedures, and more than 30,000 cataract surgeries. He has received refractive surgery accreditation from Singapore National Eye Center. He has received international fellowships from Italy, Sweden, and Harvard. He is the first to perform Bowman's layer stromal transplant for advanced keratoconus in India. He has received American Academy of Ophthalmology Award 2020, International AO Award 2022, Best Paper APO 2019, Best Video AO, Best Paper ASCRS, Best Poster AO 2023. He has presented 129 free papers, 28 posters, 106 invited talks, and multiple publications. I welcome Dr. Madhu.
Thank you, ma'am. Thank you so much for the kind introduction. And firstly, I would like to thank Prafulla for having me in this webinar. It's an honor to be presenting in a DOS webinar. And I see from the past few months, DOS has been doing excellent activities, especially webinars. And also I wish them all the best for the upcoming midterm DOS. And so without much delay, I'll start the presentation. Yeah. Are my slides visible? Okay. So the topic that I would be covering in the next 15 to 20 minutes would be on meibomian gland disease, diagnosis and management, which is a very important part while understanding dry eye. So I have no financial disclosures, and I thank Cipla for supporting this educational endeavor. So the scope of this talk would be under the following headings. We'll have a brief background about the disease, and then go about to see how we diagnose this disease and what are the management options that are available in treating this condition. So if you see the definition of meibomian gland dysfunction, it is a chronic diffuse abnormality of the meibomian glands characterized by terminal duct obstruction along with qualitative and quantitative changes in the secretion that comes out of it. So here, one important word that I would like to stress is it's a chronic disease. So whenever you're treating MGD, so don't be in a mistaken thing that you're going treating something that's acute, and once you treat it, it's gone forever. So this is more like a chronic disease that requires continuous monitoring, continuous change of treatment depending upon the degree of disease. And this education has to be given to the patient also. Otherwise, patient, if he feels it's something like a single time thing, he may be fed up with the treatments that we are offering him. So I think in the first sitting of when you diagnose MGD itself, I think this communication that this is a chronic disease, it will have its ups and downs is what you have to communicate clearly to the patient. So coming to the meibomian glands, so if you see in the upper lid, there are around 25 to 40 glands that are around 5.5 millimeters long. And in the lower lid, there are 20 to 30 glands that are shorter with 2 millimeter length. So each gland again has an individual 10 to 15 secretory acini, out of which the meibum is secreted that forms the lipid layer of the tears. So just for comparison, on this side, you can see how the dropout of the glands look like when compared to the glands which are normal here. Similar to that, you can see the lower lid where there is a dropout. So coming to how do we diagnose this condition? I think we need not have fancy equipment like meibography. Most of the existing equipment that you have in the OPD, which will have an infrared camera, would be helping you to pick up this meibomian glands. If you don't have even access to that, they'll show you a simple do-it-yourself technique. And there are some other dedicated and advanced diagnostics that are available. And I'll also touch upon IVCM and its role in meibography. So if you see, so this is how the meibomian glands look on white light illumination. And once you put the infrared camera on, you can see this meibomian glands. So in your OPD, starting from your autoref, NCT, your IOL master, fundus camera, and even your specular microscope. So any machine that has an infrared camera, maybe you'll not be able to record it, but you'll be able to visualize the meibomian glands as shown in this picture. So all these pictures are taken by the first pictures are by the autoref and so on and so forth. So I think if you can start utilizing the equipment that is already available to you in your OPD, you can start visualizing these glands. So if you don't have access to any of this, still there is an option that you can buy these thing from the Amazon. It's available. It's called as the 850 nanometer light source. That's available for around 7,000 to 8,000 rupees. And then what you need is to have a camera that has an option to do the infrared filter, and then you can pick up these glands. So coming to the advanced beamography techniques, I think LipiScan was one of the initial things that started to visualize the meibomian glands. And so this is how it looks with the infrared imaging and transillumination. It highlights even more, showing the individual acini. Next, the recent advances in meibography are the 3D modeling with help of Hydra that helps you auto-detect the glands and also give you the volume of these glands, like how voluminous they are and how the meibum is being secreted through them. So it gives you a 3D modeling with help of the newer technology called as Hydra, that is from SBM. So depending upon the grade of the dropout of these glands, you can use this Meibo scale. So depending upon the degree, so suppose the loss is less than 25, it's the first degree loss. If it's from 26 to 50, you call it as a second degree loss. And if it is 51 to 75, you call it a third degree loss. And anything beyond 75, it becomes a severe or degree 4 loss of the gland or meibomitis. So same, you do it for the lower lid and upper lid as shown in this figure. So what is the role of in vivo confocal microscopy in meibography? So if you see, the first one is the normal thing that you see. So when you use in vivo confocal microscopy, you can see this intraepithelial and intragranular thing is normal. The lumens are normal. There is no inflammation. Whereas in the second picture, you can see lumen obstruction with minimal inflammation. And in the third picture here, you can see intraepithelial and intragranular inflammation. And finally, here you see fibrosis and epithelial destruction. So I don't think IVCM we do routinely, but sometimes when we do this MGD treatments and patients don't respond, I think those are the category 3 patients where fibrosis has already happened and epithelial destruction has happened. And in these cases, like you try the recent advances, recent treatments like IPL or LipiFlow. So all these technique may not be useful in these cases. So definitely in cases of lumen obstruction or intraepithelium and intergranular inflammation, these treatments will have a role. But once there is fibrosis, I think it will not be much of use. So now coming, how do you measure the lipid layer thickness and the non-invasive TBUT? So tear film analysis is also equally important in MGD as important as visualizing the meibomian glands. So the lipid layer is the outcome of the meibum that comes out of these glands. So the normal lipid layer, again, this is available in LipiView. So what happens is it projects this square-like things onto the cornea, and from there it measures the lipid layer thickness. So when you get a value of more than 100 nanometers, it is considered to be normal, and anything below it, the lipid layer thickness has decreased, corresponding to the decreased secretion in the meibum. So this, when compared, it is also included with the correlated with the meibomian gland dropout. It gives you a more comprehensive report. So correlating, so whenever there is a lot of meibomian gland dropout, correspondingly the LLT will also decrease in these cases. So that is how LipiView correlates both meibomian gland dropout and the lipid layer thickness. So coming to non-invasive tear breakup time, it is available in most of the topographers now, wherever a Placido disc is there. So this is a simple procedure where you ask the patient to blink twice, and they see the green thing is the new tear film that is formed, and these spots are the, I'll just repeat the video again. So once the patient blinks, the tear film is formed, and the red spots are the dry spots that appear immediately. So here in the picture below, you can also see at which exact time the dry spots have been formed. So this is better than the invasive tear breakup time to see the quality of tear volume. So coming to the management of MGD, it starts from lid hygiene, giving osmoprotection, tear substitutes, oral tetracyclines, and all these things. So these things I'll be telling you in the coming slides. So medical management, if you see the effect of bacteria that is there in the MGD process, I think lipases have a very pro-inflammatory role in this. And also MMPs also play an important role. So oral doxycycline, not for its antibiotic properties, but for its anti-MMP activity, has a role in MGD. You can usually use it 100 mg BID for 2 to 3 weeks. And sometimes if it is very severe, we can also continue to use it for 2 months. And topically, we try to give erythromycin 1% ointment for night time. It usually has its effect and usually not required for more than 2 weeks of a time. And if the inflammatory component is more, there are also erythromycin dexamethasone combination drops that are available. This also can be used BID or TID for 2 weeks. And coming to anti-inflammatory therapy, steroids are rarely used as the first line of therapy. So we usually start off with cyclosporin that is well tolerated. So you can start off with 0.5 0.1 and then go to the higher concentrations. And cyclosporin continuously can be used for 3 to 6 months. And once it is not controlled, the inflammation is not controlled with cyclosporin, then we tend to go to loteprednor or higher steroids like dexamethasone. These also we try to use it like a buffered way, like we use it for 2 weeks, stop, and whenever the patient is symptomatic again, then give again for 1 week or 10 days. Liftigrast was not available all these days, but I think recently we also have Liftigrast in India. I think it has come recently into the market, so it's now available in India. But the experience with Liftigrast so far has been not much. And coming to the role of essential fatty acids, or omega-3 fatty acids, I think the DREAM study from that was published at JSCRS told it doesn't have much role, but the cornea committee at the ASCRS, they feel that there is no harm in using it. So it is up to you. If you want to use it, you can use it as an adjunctive therapy. And usually when we use this omega-3 fatty acids, you can use it continuously for 3 months, give a break and again use it like that. And sometimes the meibomian glands also can be associated with blepharitis and demodis that can be treated with tea tree oil, lid scrubs, and lid hygiene. So this is broadly the medical management that we do. Now coming to the dry eye polymers that are useful in these conditions, I think sodium hyaluronate has a very good role, especially dry eye that is associated with post-surgery. I think Flogel HA from Cipla, I'm quite happy with them from the last few months that I have been using, and we routinely put them for all these cases. When compared to other molecules, it binds effectively and also resists dehydration. It promotes epithelial wound healing faster, and the viscoelastic property enhances the residing time when compared to other molecules. And when it comes to digital eye strain associated with MGD, I think Flogel Hydra would be a better choice, where you have PEG, PPG, and HP GOR. So this combination works well in cases where you are looking at digital eye strain. And this has been already mentioned. The residence time is more in PG, PEG, and HP GOR. And also the tear film breakup time improves to 60% when you use this combination. So coming to the other methods of managing MGD, I think this is one of the simplest method. So once you ask patients to do their hot water fomentations for maybe about 1 or 2 weeks, you can call them back to your OPD, and these Mebum expressing forceps are available and with many companies. You can choose whichever is comfortable to you. So once the hot water fomentation is done, so you can apply some Paracaine and gently squeeze out that Mebum that is, you can see that is being expressed out with the Mebum expressing forceps. So this, I think all of us can do it under the slit lamp for cases that require. This will give immediate symptomatic relief. Next is the LipiFlow. This is the new technology that has been widely used for meibomian gland dysfunction. This is one of the most comprehensive thing because it gives heat. When you put hot compresses, usually you put it on only on the lid, but here it also produces heat from the inside as shown by the red arrows, and it also compresses the lid so that the any blockage that is there and the meibum is liquefied and it comes out smoothly. So that is the functioning of the that is how it functions, and it clears the blockages that are there in the acini. So this is one of the treatments that has gained popularity, and this is called as the LipiFlow. So next you have something similar from Novartis, but this is still not available in India. But when you go to Academy and all, you can see this. It's quite nice. It holds the lid and the temperature increases to 41 degrees. And once it increases to 41 degrees, from there, once you press the button, it expresses the meibum like that. And that is how the meibum is expressed out. So heat and mechanical expression is the combination of, and this is called as the iLux. Next, there is something called as intense pulse light therapy. So we have been using this, and almost we have used it in around 70 to 75 cases so far. Usually we do 2 to 3 sittings 1 month apart, and it can be combined with hot water fomentation for better results. Usually we do it for refractive surgeries or premium IOLs where you expect a good refractive outcome and there is a suboptimal tear film. And definitely for the first sitting, there is a wow factor, and the non-invasive T-bud increases and patient also feels symptomatically better. So I think this is one thing that we can try. So this functions by, this is how it is done. You put the lid guards on, and then with the help of this intense light therapy, you give 4 or 5 shots. So this is how you put the thing, and then you put a jelly. It's almost like that ECG jelly that comes. And this is how you put 4+1 at the canthus, 4+1 at the canthus for both the eyes. And then it is done. So here you need to adjust the intensity of the pulsed light depending upon the pigmentation of the skin that the person has. So it has a clear skin tone guide that helps you to identify the skin tone of the patient and adjust the pulse light accordingly to it. And this is also a simple office procedure that you can do. So newer techniques like neurostimulation has also now recently gained popularity. Like what happens is they try to stimulate the nasal thing, and that will in turn give the lacrimal gland stimulation. So this is how the thing looks. So once you put it into the nostril, then it creates that sensation, and the reflex steering will start coming with this. So this is also yet to come in India. So these are some of the things that can be used in the treatment of meibomian gland disease. So all said and done, the wisdom from MGD treatments is, in a way, MGD is like your spouse. You pretend to control it, but in reality, the control is only transient. Thank you. Thank you for your time and attention. Now I'll be happy to take any questions.
Thank you, sir, for your advanced insights into MGD, which is often underdiagnosed or mismanaged. And especially it was encouraging to hear about the advancements in management that could really offer help to many patients. So I would like to invite our distinguished panel of experts and discussants for today who can offer their unique perspectives on MGD. Dr. Parul, Dr. Surbhi Dutt.
Yeah, actually, the whole thing was quite precise. Everything was actually taken care into, and it was nice to see the expressing video was actually very, very clear. You know, the oil coming out of the glands, very well done, very well. I just had one question. When you see a patient of MGD, do you have any sort of videos to make the patient understand, or do you, because sometimes even in the AR, you have the infrared. Do you have any pictures that you can actually tell them the grade of what severity you are? And does the patient always understand it? Do they actually do the hot compress in a proper way, or do they come back to you in a, let's say, 4 weeks time and say it's not helped me at all? How does it go?
Yeah, I think hot compresses, at least in our experience, most of them don't do it at home. They do it for like 3-4 days and then stop doing it.
Yeah.
So that is the reason these things like LipiFlow or IPL have gained popularity. Especially if you are talking about a pre-op patient, I would not completely rely on hot compresses.
Okay.
So I would,
So how do you convince the patient then? Because
yeah,
if you
so
have to give them, yeah.
yeah, I think meibography helps a lot, and the non-invasive T-bud, where you get an objective time of what is their tear breakup time, and also Meibo scale where we can show the dropout. So when we tell them, they usually are willing to get it done.
That's good. So you do it for pre-op also
Yeah,
before
pre-op
taking the
for all
session?
our multifocal, or I mean trifocal IOLs and our refractive surgery, Dry eye workup is done as a routine.
Okay. Thank you.
Because what happens in most of these cases, patient may not be symptomatic. The tear film will be suboptimal, but the surgery, after the surgery, they'll start become symptomatic.
More simple. Yes.
So in these cases, your IOL is perfect, your LASIK surgery is good, but post-op, because of this, they feel that they'll attribute this to surgery. So that is what I keep telling to my fellows or residents also. Anything you diagnose before the surgery is patient's problem. Anything you diagnosed after the surgery is a complication that he'll attribute to the surgery.
That's very well put. That's absolutely correct.
So
Yeah.
should there be a standardized diagnostic protocol or an individualized approach is better?
I think it's more of an individualized approach, depending upon the grade of the meibomian, like what is the condition of the patient and all.
So then how important is imaging such as mammography or infrared imaging? Like, is it essential to use these tools?
Yeah, maybe we can just start off by doing a proper slit lamp examination by pushing the glands and seeing how the meibum is expressing. That itself will give a good clinical cue. So once you know that the glands are blocked, maybe then you can take them to the next step of meibography. Your routine slit lamp examination will usually pick up, because once you start seeing at the slit lamp, you see debris, you see dry spots and all. That is when you can see. I think Lesamine green staining also works very well, especially when you do the lid margin staining with Lesamine green. And whenever it takes up more than 25% of the width or 2 millimeters of length, that itself also gives you a cue that there is a problem with the meibum. Madam Parul ma'am, you are on mute.
Yeah, so Dr. Madhu, very nice talk, and you elaborated everything very nicely. So in MGD, the quality as well as the quantity of meibum is affected. So
Yeah.
it's very important to see the type of secretions from the lid margins also. So we
Yes.
have grading of MGD also, like if the secretions are cloudy, or that is grade 1, or it
Yeah.
is milky white, then it is grade 2. If they are frothy, then grade 3, and grade 4 will be thick inspissated secretions, as we can see in even Steven Johnson patients. So
Yes.
proper grading should be done at least on slit lamp before proceeding to other diagnostic approaches, and then we can individualize the approach according to
According to the grade.
the
Yes.
and even some patients of acne rosacea, they have a lot of telangiectasias.
Correct.
So
Correct.
as rightly mentioned, we can do IPL for them. So
Yeah.
IPL would lead to coagulation or thrombosis of these telangiectatic vessels on the lid margin and lead to decrease in the reddening effect, which can be seen in the lid margins of such patients.
Yeah, I think that's a very good point, ma'am. Acne rosacea, IPL works very well. Very well. Yeah.
Very well. Yeah. And we also need to classify MGD as the hyposecretory forms or the hypersecretory forms. So hyposecretory will be cicatrical or non-cicatrical. Cicatrical will be typically in SJS patients or
Correct.
trachoma patients or pemphigoid patients, whereas non-cicatrical will be in other conditions like Sjogren's can be non-cicatrical, though in
Yeah.
later it can proceed to cicatrization. And the hypersecretory will be seen in the acne rosacea and the seborrheic patients. So we need to classify like that also.
Yes, madam. If you see the IVCM, the fibrosis part correlates to the cicatrizing one.
Yes, yes,
Where
definitely.
IPL may not help much or LipiFlow.
Yes,
Whereas the acne rosacea and everything, where you have more of an inflammation,
yes,
that is where these therapies do work well.
do work well. Yes.
Yes. Yes.
So that was a really nice talk. And I had a question. You showed that one of the causes of meibomian gland dysfunction is the Demodex infestation as well. So how often do you come across such cases where primarily the Demodex was the cause of MGD? And how do you identify all those cases?
Like Demodex is easy to identify even on a slit lamp. And once what happens is not the regular Demodex that you see, but these are more like you can see that they actually try to impregnate the lid margin, where they go and block these orifices and they infest there. So these are the conditions that can lead to mebomitis. So in these cases, I think sometimes you can even the tea tree oil and all maybe of limited help. They can be helpful, but most of the times you need to go under slit lamp and try to pick those Demodex individually that are impregnated in those margins and put some azithromycin and dexamethasone combination kind of a thing to treat that one.
Because what we know from literature so far is like the Demodex follicularum is the one which is associated with blepharitis, and the
Yeah.
brevis one usually goes into those meibomian gland orifices, and
Yes,
those are
yes.
the one which are responsible for causing this
Correct.
meibomian gland dysfunction.
Yes.
We can also identify Demodex by the typical cylindrical dandruff dandruff-like
Yeah.
it causes on the lash follicles. So
Yeah, that is the one which is primarily responsible for the the blepharitis.
Blepharitis.
Yeah,
Blepharitis. Yeah.
blepharitis. Yeah.
So what we were speaking about is the brevis form that you mentioned.
Yeah.
Yeah.
So we have a question.
Yeah.
What is the current consensus on the most effective treatment? Like, how do options like warm compresses and lipid-based artificial tears or IPL compare in terms of long-term efficacy?
Say, as I've told you, there is no long-term efficacy for any of the things that are available right now. So the best possible, like if you take LipiFlow or IPL, they work maybe for 3 and sometimes 6 months. So after 6 months, you either need to repeat the sitting or you need to treat them medically. So this is not like something that you treat it at once and it's gone. So that as in the presentation when I was starting, that was the thing I was telling you, that patient education is very important. So to put it very bluntly, like sometimes I tell them that it's like your BP and sugar. It's not going to vanish away completely. We're only going to control it. Because of certain factors, it can again flare up and we have to treat it whenever it is you're feeling the symptoms.
Right.
And we do aggressive therapy only when the patient is very symptomatic. And as I've mentioned, preoperatively, when we need a good ocular surface, even to take a biometry. So these are the conditions where we do aggressively. Otherwise, we try to manage them conservatively as far as possible.
So you have to balance both conservative treatments as well as
Yes,
the
yes.
advanced
So
intervention.
because if the patient is not symptomatic, there is no point in pushing them for treatments that we're difficult to convince them. But once they are symptomatic, they readily accept it. And one more condition where they accept these treatments is pre-op, as I have told you, pre-refractive outcome surgeries. Yeah.
Hi, good evening, everybody. Dr. Madhu, a very nice talk
Hi,
on
Akira.
something very
Thank you.
important. Hi. So I just, you've covered everything so beautifully. I just wanted to talk about something new I saw at AO this year. So, you know, the
Okay.
problem with LipiFlow and IPL and all these devices majorly is that the patient has to keep coming back to the office to get them done, and also they are expensive. So just
Yes.
like how you talked about the device from Novartis, so recently I saw a device called as New Lids, which is like a pen, and they have two versions. One, you can use it in office, or you can also give it to the patient. So you put a gel on it, and it kind of generates a little bit of heat and causes a little bit of vibration. You put it on your lids, and
Okay.
it just for 30 seconds on both the eyes, and I think recently it's FDA approved as well. And it's
Oh,
not as expensive. I think it's right now priced at about $300 for the device and $30 for changing those tips. So
Okay.
probably patients who can afford, something like this might be the future to give them something, because, we know how tedious it is to explain to the patients to do warm compresses and follow up with the treatment. So if they have something, it's like an electric toothbrush that you
Yeah.
kind of put in your eye and you just do it for 30 seconds, both eyes. So it's like, we can tell them when you're brushing your teeth, kindly please do this also. So that might be something that will help us with compliance in the future.
Yeah, I think that would be very handy for the patients, and they would be taking care well. Yeah, and from what you're telling, it's not expensive also. Yeah.
Yeah. So let's hope it's something like this
Yeah.
comes to India soon.
I saw a similar thing for blepharitis, but it didn't have the heat part.
Yeah.
It just had the brush that drizzles the lashes and the flakes used
Yeah.
to. So I think now the heat part is the new one, and if it comes, really, it's a good thing. Yeah.
Yeah.
And I think one more Dr. Cornea fellow I saw in our group, I think he also has this heating pad kind of a
Yeah.
thing. Yeah, I think
Dr.
that's
Hemal Kenya, I think he's come up
yes,
with
exactly.
yeah,
Hemant
yeah.
Kenyas also, I think, is a good option for the heating purpose. Rather
Yes,
than
yes.
warm compresses, I think this one is more it's more
Doable,
easy
yeah.
to use. Yeah, yeah.
Absolutely.
Yes.
So how do you assess and manage patients with chronic or progressive MGD?
I think,
Like,
yeah,
what are the
same.
best strategies to prevent disease
Right.
progression and reduce the risk also?
I think not much can be done in progressive part, I think, because it's as on when you see and you treat it. But I don't know whether we can give something prophylactically to stop it from progressing. Most of the times it is chronic and it has its ups and downs. And so as and when the patient is symptomatic only, we treat them. Otherwise, most of the times, most of them are happy with simple artificial tears, especially lipid-based artificial tears. I think they do well and they don't complain. But if their profession is more towards the digital screens and all, that is where you can tell them to take some breaks and plan their work accordingly, because this will have an additive effect on the MGD. Their digital strain also will add to the dryness. So that is the modifiable risk factor there. Whereas in MGD itself, I don't think much is modifiable there when compared to the other forms of dry eye.
And even in contact lens users, we should caution them to avoid too long a duration, because contact lens in itself lead to increased epithelial turnover, and that epithelium, it blocks the leads to hyperkeratinization of the meibomian duct terminal ducts, and that itself blocks the meibomian glands, so it can lead to worsening of the MGD. So that can be a preventive factor to
Yeah.
have better contact lens hygiene and wear them for smaller durations.
Yes.
Dr. Surbi, ma'am.
Yeah, so I recently have acquired a very small OPD based instrument which is called as Dredger. So I am trying to actually, which is why I was searching. I don't have an image, but I have actually a small sort of a clipping video, but I don't know how to share it on this forum. So I'm not sure how to share it here.
You have it in your gallery, ma'am?
I have the video, but I am trying to share it here. Yes, I have it, but how do I do that? Otherwise, I can put it I can send it to Anu, and probably she can just share it to all. It's a
Yeah.
very, very simple device, and it takes care of both the upper lid and the lower lid, and the patient responds really well. It's a sort of a Nebo kind of, the similar forceps which you showed, but it is not. It is shaped in the form of a cup. So it's
Okay.
very safe, It's nice. I'll send that to Anu because I'm actually out somewhere, but I just thought I'll just tell you people that such an instrument is quite handy in the OPD.
Correct.
Yeah.
Sir, what role do systemic conditions like rosacea, diabetes, and autoimmune, like how should we screen for these associated conditions in patients who present with dry eye to us?
Yeah, rosacea, I think, as ma'am pointed out, on slit lamp examination itself, you can pick it up. When you see the lid margins, you have this telangiectasia that is there. And also, when you look at the patient, no, they usually have the features also, like in the face when they have this rosacea, acne, and all. So it's like more like on the cheeks and all you can see. So that is one condition. And diabetes, I'm not very sure if it because there are some studies that tell it is associated with diabetes and hyperlipidemia and all. But practically, I'm not very sure how much they're really associated. Ma'am, in your experience, do you see any positive correlation, diabetes and MGD?
No, I've not seen any positive correlation, though diabetics do have increased dry eye, but
Yeah.
not as such. Like
Yeah, dryness is definitely more. But
dryness, definitely more, but
MGD, I don't see. Yeah.
significantly more in diabetics. No.
Yeah, even regularly what we say is in thyroid and
Yes.
diabetes, you often see as dry looking ocular surface, but it's not totally attributable to MGD.
MGD, exactly. Probably related to the neuropathy caused
Yes.
secondary to the diabetes. So that
Yes,
causes
yes. That is the more causative factor.
factor. Yes.
So we have one more question. Can the oral treatments like omega-3 supplements and doxycycline play a significant role in managing MGD? And do we have any evidences to support their use?
Doxy 100%, it has a role because of its MMP activity. Doxy is, you have a lot of studies and articles that you can go through. But omega, I have told you, DREAM study tells it doesn't have a role. But if you see again the ASCRS recommendation, the cornea committee there recommends to use it.
Yes.
So because omega-3 fatty acids anyway are not going to do any harm. So I personally feel you can give it like an adjuvant and see. Recently, I think from the Narayan Nethralaya group, they have been using the maquiberry extract also. They tell that also has a good antioxidant effect. So I think we can try whichever the patient is comfortable with. Omega-3 fatty acid, one more practical point is the pills are very big and the aftertaste is very bad. So the compliance is literally very less. So what I usually tell them is you take the food that is rich in omega-3 fatty acids and also try the MACV that is there. Previously, we used to get them from US called as MACU Bright. Now, few Indian companies are also producing it, and the brand name is called MACV, I think. It's a MACU berry extract. So that is our experience with the oral therapies.
We even have a algal form of omega-3 fatty acids now. So some come up with the vegetarian sources, and they
Yes.
don't have that typical fishy smell or any belching or anything
Yes.
of that sort. So I think that is a very good option. And there are companies which have veg options also.
Yeah.
And another thing which we can tell the patients who have to take the salmon oil based omega-3 fatty acids is that you should take it with meals.
Meals.
Don't take it empty stomach. And another very important thing is to ask for any history of aspirin use or any blood thinners, because we don't want to thin the blood too much. These omega-3 fatty acids, they have a tendency of thinning the blood. So if the patient is already on blood thinners, we need to caution them about that.
Yes, that's a very practical point. Yeah.
Yeah, Anu, I've
Yeah,
just
ma'am. I've
actually
received.
shared it with you. If you can share it, you just try it. I sent it to you on your phone.
How to share
Chat, WhatsApp. I also don't know.
You have the share button in your screen, down the green one.
Yeah.
Just try sharing with that. You have it on your screen right now. You opened it.
Yes.
You keep the video open and then share. You can select that screen.
Where's my phone? Actually, there's no option of sharing a video. So I could not.
So by the time things are getting ready, like these days, as we were discussing, like whether we see any association, positive correlation with the, prevalence of diabetes and women gland dysfunction. So so far we have seen an association, very strong association with this digitalized strain, what we had discussed in the last episode. So it's very common, like people who have the symptoms of digitalized screen, they do have coexisting women gland dysfunction as well. So
Yeah.
what is your take, sir? Can you please put some light on?
Yeah, I think, this is a very valid point because now digitalized strain we are seeing in a lot of people, and alarmingly even in children also, you are seeing this because of their dependency on digital screens. I think okay, you want to show the video? Yeah, go ahead. Okay.
Press it like this. This is on the lower lid. And when we go in the upper leg, we just turn our hand and we take it up like this. So we're compressing it part by part. And I have seen a lot of response of this.
Yeah, thank you. Thank you.
Thank you, Anu. Thank you, Anu.
For sharing it. Quite nice. So where did you get this, ma'am?
Actually, that is the crux of it. I'm not getting the person's contact number. I'm trying to trace it. This person gave it to me almost 2, 3 months back, and after that, I left it. But suddenly, I cleared my drawer and I saw it. It's a huge mistake from my end because there's so many people who have asked me for his contact number and I have no clue. And he just gave it. He said, "Ma'am, आप try करो. अच्छा लगेगा तो कर लेना उन्हें." And now I don't know who gave it to me. No idea.
Yeah. Okay. So I think, thank you. Thank you for sharing that clip. I think it's very nice and handy. So
Yeah, pretty.
before this, you do some hot water fermentation, ma'am, or?
Yes. So I actually have used this only for when I am actually seeing the patient on the slit lamp, and if I feel there's actually the purulent kind of discharge coming around, because those are the cases which I feel personally the hot compress will not really help. And so you actually sit and express the glands, and it's helped in all these kind of styes which are actively coming around. The patient is getting those early symptoms of pain, so this
Yeah.
helps in those cases also.
Yes. Yes. Yeah. Yeah. Thank you, ma'am. Thank you so much for sharing that clip. It was
you.
quite nice.
And I'm sorry, but if I get it, I will share it, the
Yeah.
contact number. Which is why I'm sharing it more so that if someone hopefully finds out, can also share it with me,
Correct.
that I'm hopeful somewhere someone has also got the similar kind of instrument.
Yes. Yes.
And how do you sterilize it?
I sterilized with Terilium and the swabs. We just keep it, it's not really causing any kind of infection. So it's an alcohol swab, and just keep it in the Sterilium for some time.
It's good to see that so many people are having access to these, instruments. But unfortunately, we do not have this instrument. These kind of instruments that at our setting. So I just wanted to add or emphasize the role that the warm compresses and the lid massage does. It significantly, helps. And if you are teaching your patient correctly, I think that is something really very, very important. And that really works.
Yes.
You just have to tell them the correct technique of doing warm compresses and lid massage. Because all the machines that we are using, finally they're doing the same thing.
Yeah.
Dr. Anu, are there any questions from the audience? Because they have a different link, no? Please check Bhageshwar or Sharik. Please let us know if there are any questions from the audience.
We have a question from Dr. Gunjan. Like, how many IPL sessions can be done maximum in a year?
Usually we do the first sitting, then do the second sitting after 1 month. The third sitting, the company people ask you to do immediately after 1 month, but we usually defer it. Only if the patient is symptomatic, we do. Otherwise, we can do it after 3 months. So far, I did not do any treatments. I mean, maximum I did was 2 in a year. Third one was rarely required.
So how do you foresee the role of personalized or precision medicine in MGD management?
I'm not very sure, but I think definitely it will have a role, like in the same direction as targeted therapy. If they're able to do specifically something for MGD, and if they're able to do, then it's good.
Thank you, sir.
We also have some intraductal probes to open up the gland orifices. I think they
Yes.
are the Maskin probes.
Mm-hmm.
So we can use those also. I think they are 1 to 2 mm long. We can
Yes.
just probe the gland orifices and then clean up the secretions
Yeah.
to unblock the glands.
Yeah.
Thank you, sir.
There was some discussion about digital eye strain and MGD association. I think I missed the discussion part. But how is the mechanism? Most of us claim that yes, there is definite association. Are there any mechanism, specific pathogenic mechanism described for that?
I don't know. You can attribute it to the reduced blink rate also. See, because digital eye strain, the one thing it's strikingly there is the reduced blink rate. So once there is a reduced blink rate, I think that is correlates with your mebum secretion, no? Because it with each blink, that also
Yeah,
has
that
a
is, yeah, probably because this tear film secretion, no, that is impacted by
yes,
this parasympathetic pathway. So
yes,
this
yes,
definitely there is some link between blink rate and your
yes.
secretion, mebum and
Yeah.
gland
So
secretion.
that was what I was able to feel in most of the cases. And
Yeah,
you
and
can't actually separate them from each other, especially digital eye strain, no? As you rightly pointed out, at least 70% of them will have some form of MGD.
yes, and also I don't know how frequently you see in your practice. What I have seen, even we are doing a thesis on that. Most of the time, when MGD doesn't respond beyond 2 year, 3 year, these patients they do have some psychological component associated with that. And you won't believe till now we have screened 12 patients. Those patients who were diagnosed with MGD, they were getting standard treatment, but still not responding. Still, they had some complaint. In spite of using medication for 3 months, we are still not happy. So we just asked them to go through a set of questionnaire designed by our psychologist. And what
Okay.
we found that out of 10, almost 7 patients, they have some psychosomatic components. And we are treating them. And I hope we get the result after maybe 6 months. So we are trying to see with the same treatment with add-on psychological therapy, is it are we going to get any subjective as well as objective improvement in dry eyes symptoms associated with MGD?
Okay. That's interesting.
A lot of people are there from Western world because in
Okay.
India we don't emphasize much on the quality of life. There,
Yes.
if you go through the literature, anxiety, depression are definitely there in dry eye patients. And those patients who had pre-existing psychosomatic diseases,
By the
that got
questionnaire
flared up.
itself, you are able to make out.
We are doing a questionnaire
Okay.
that my thesis candidate will do. Suppose
Okay.
he suspect that some questions are not appropriately answered, then we have a clinical psychiatrist. So he then evaluates them
Okay. How
thoroughly.
easy it is to convince them to go
It is
to
very, it's very difficult. Half of the time, patient says, ki, no, we don't want. Even I shared one instance of me when we asked such question. Few patients they said, ki, no, now we are feeling better. Their symptom disappeared immediately.
But honestly, if we do this in private practice, the patient will just run out from us. It's not gonna,
That's why I
it's
said
not gonna happen.
patients whom we are treating for 2 to 3 years with standard treatment. Those patients.
Yeah. Yeah. No, I think it's something interesting you have to look into. But the practical point is in India, still psychiatry is considered to be a taboo where people don't seek out that help. I think post-COVID that has changed a bit, but we still have a long way to go.
Counsel them. We never counsel them that you have some psychological component.
Correct.
It's reverse counseling because you are using so much medication. You may have some anxiety associated with that.
Correct. Yeah.
Thank you, sir. So as we come to the end of today's webinar, I'd like to thank you, Dr. Madhu, sir, once again, and a special thanks to our discussants and panelists for this highly engaging session. We also thank our attendees. I hope we found you found the session helpful. And thanks to our DOS team for making this webinar possible. So stay tuned for our upcoming DOS Super Tuesday webinars. Thank you, everyone. Have a great
Thank
evening.
you. Thank you so
Thank
much.
you,
Thank you.
Thank you, Dr. Praful.
Thank you all once again for this opportunity. Have a good night.
Good
Bye.
night.
Good night, everyone. And thank you to all those 200 plus audience for the live viewership that we get today. Thank you so much.
Thank you, Praful. Good night.
Yeah,
Thank you.
that's